good morning to everyone attending today. It's my pleasure to introduce our first speaker, Dr. Han Winhui. She's a dermatology lecturer in the University of Malaya Medical Center. She obtained her MB-CHB in 2008 and obtained her MRCPI in 2014. She's been working with us for the last few years, and she's very active in clinical work, teaching, and research. And she's also been an investigator in a few clinical trials on eczema. So it's with great pleasure we welcome Winhui to take the stage.
Thank you, Prof. Kwan, for the kind introduction. Good morning, everyone. I'm Dr. Han, medical lecturer from Division of Dermatology, Department of Medicine. So the title of the talk this morning is on World Psoriasis Day 2023. This is the outline of my presentation, which will touch on the burden of psoriasis worldwide and in Malaysia, pathogenesis of psoriasis and its associated diseases, types of psoriasis, the treatments available these days for psoriasis, and a case study to conclude my presentation. Psoriasis is a common skin condition, and if it affects 2 to 3% of the world's population, which is equivalent to 125 million people worldwide. In the United States, more than 8 million people suffer from psoriasis, and approximately 1/3 of psoriasis patients will go on to develop psoriatic arthritis in the future. This is a debilitated disease affecting various small or large joints in the body, causing significant impairment in patients' activities of daily living. This is a map of the incidence of psoriasis patients worldwide in 2019. The incidence is the highest in the UK, European countries, followed by United States of America, South America, and Australia. The incidence of psoriasis in the Southeast Asia is much lower. So what about the burden of psoriasis in Malaysia? Using a population-based cohort study between January 2010 and December 2020 in Johor Bahru, Dr. Chun and team found that the burden of psoriasis over an 11-year period is as follows, where the incidence was 34.2 per 100,000 person years. So these are the distribution of the various types of psoriasis affecting our Malaysian population, where plaque psoriasis predominates, followed at 85.1%, followed by guttate psoriasis at 2.9%, erythrodermic psoriasis at 1.7%, pustular psoriasis at 1%, etc. So what is World Psoriasis Day? This is a day where it's celebrated on 29th of October every year, where it aims to highlight challenges encountered by patients suffering from psoriasis and psoriatic arthritis in terms of associated comorbidities, complications of psoriasis, and treatments. These are some common myths about psoriasis and the dilemma that patients face on a daily basis. If they are not educated properly, these are some of the myths. So they will ask things like, is psoriasis contagious? Is psoriasis just about dry skin? Doctor, can I swim in a public pool? And psoriasis results from poor hygiene. Psoriasis only affects the skin. And is there a diet to cure psoriasis? And finally, they are always quite embarrassed to wear black clothing as their dandruff is all over their shirt. So what is psoriasis? Psoriasis is a chronic inflammatory skin condition characterized by clearly defined red and scaly plaques. It is characterized by complex alterations in epidermal growth, differentiation of keratinocytes, and multiple biochemical, immunologic, and vascular abnormalities. This slide shows the pathogenesis of psoriasis, which is a T-cell-driven disease. Triggers such as infection, drugs, and physical injuries will stimulate dendritic cells to release pro-inflammatory factors such as IL-23, IL-17, TNF-alpha, and interleukin-12. These cytokines induce Th17 and Th22 cells differentiation, resulting in production of various psoriatic cytokines such as TNF-alpha, interferon gamma, interleukin-17 and 22, which acts on keratinocytes to amplify psoriatic inflammation. In addition, skin-infiltrating cells such as gamma delta cells contribute to the disease development by affecting the Th17 and T regulatory cell balance, which plays an important role in the pathogenesis of psoriasis. So psoriasis is more than just a skin disease. There is increasing evidence that psoriasis is a disease of systemic inflammation with ramifications for multiple organ systems, resulting in psoriatic arthritis, cardiovascular disease, metabolic syndrome, inflammatory bowel disease, celiac disease, etc. The term psoriatic march is coined in a similar context as atopic march, which describes the natural progression of allergic diseases such as atopic eczema, asthma, and allergic rhinitis over the course of infancy and childhood. Systemic inflammation in psoriasis may cause insulin resistance, endothelial cell dysfunction, and subsequently leads to atherosclerosis, myocardial infarction, or stroke. Therefore, the term psoriatic march, which suggests a causal link between psoriasis and as a systemic inflammatory condition with cardiovascular comorbidity. This slide shows the similarities of inflammatory cytokines involved in various inflammatory disorders. The main similarity is that all of the listed diseases here are also mediated by IL-17 and IL-17A pathway, hence indicates that patients with psoriasis, where their IL-17 pathway is already upregulated, they are also at risk of developing diseases listed here, such as psoriatic arthritis, cerebral cardiovascular disease, renal dysfunction, Alzheimer's disease, hypothyroidism, uveitis, etc. This table shows the characteristics of comorbidities associated with psoriasis. For example, patients with psoriasis has 1.7-fold increased risk of MI, myocardial infarction, 1.6-fold increased risk of stroke, and coexistence of these diseases will shorten average lifespan by 6 years. This happened as coronary artery inflammation was promoted, resulting in atherosclerotic plaque instability. Similar increment in the risk of developing various components of metabolic syndrome is also shown. For example, in the presence of psoriasis, abdominal obesity risk is increased by 1.7-fold, and dyslipidemia risk is increased by up to 5.6-fold. This shows that psoriasis is associated with multiple comorbidities. Therefore, healthcare professionals who are treating patients with psoriasis need to perform necessary screening for patients with psoriasis. So let's move on to touch on the types of psoriasis, namely plaque psoriasis, guttate psoriasis, inverse psoriasis, pustular psoriasis, and erythrodermic psoriasis. So plaque psoriasis is the commonest type of psoriasis where patients typically present with salmon pink plaques with silvery scales. And a typical distribution include the scalp, ears, extensor aspects of elbows and knees, groins, and intergluteal clefts. Second type is guttate psoriasis. It typically develops few weeks after a streptococcal throat infection, presenting as teardrop-shaped erythematous plaques affecting the trunk and the limbs. Third type is inverse psoriasis, which typically affects the flexural areas over the body, such as over the armpits, inframammary fold, groins, and intergluteal cleft. Involvement of these special sites will cause significant psychological distress to patients. Patients with pustular psoriasis typically present with crops of sterile pustules over erythematous skin, which will lead to pustular leaks when these pustules coalesce together and cause desquamation of skin. There are two types of pustular psoriasis, which are localized versus generalized. The first type of localized pustular psoriasis is acrodermatitis continua of Halopo, where patients present with pustular eruptions of fingers and toes, and sometimes involving dorsum of hands and nails. Complications that may arise include osteolysis of the distal phalanx and onychodystrophy. The second type of localized pustular psoriasis is palmoplantar pustulosis, where patients present with pustules over the palms and soles. This is commonly associated with psoriatic nail involvement. This condition usually affects adult females, smokers, and patients with type 1 diabetes mellitus. And this may rarely be provoked by TNF-alpha inhibitor as well. Therefore, it's understandable that patients with localized pustular psoriasis can be quite distressed with this condition as it affects their activities of daily living greatly. These are some of the pictures of patients with generalized pustular psoriasis, where you can see crops of sterile pustules affecting all of their body. So GPP is usually preceded by other forms of psoriasis, and patients typically present with fever that lasts for several days with a sudden eruption of sterile pustules 2 to 3 mm in diameter. The median age of onset is at the 5th decade, and in the recent years, IL-36RN gene mutation has been found in patients who present with GPP without prior psoriasis vulgaris. This is an exciting finding in the recent years, as new drugs such as spesolimab and imsidolimab had been designed as anti-IL-36 receptor antibody and proven to be effective in clearing GPP. Our center is involved in a clinical trial in studying the efficacy of imsidolimab in treating GPP patients, and it had proven to be quite effective. So the triggers for GPP include infection, sepsis, withdrawal of systemic corticosteroids, medications, and metabolic derangements such as hypocalcemia. And GPP is a psoriatic emergency that can progress on to erythroderma. Pustular psoriasis of pregnancy, formerly called as impetigo herpetiformis, is a rare variant of generalized pustular psoriasis occurring during pregnancy or triggered by pregnancy. This condition can occur anytime during pregnancy, but typically presents in the 3rd trimester of pregnancy with symmetric erythematous plaques studded at the periphery with sterile pustules in a succinate pattern. The eruption begins in the flexural areas and spreads centrifugally. The trunk and extremities are usually involved, while the hands, feet, and face are usually spared. Their nails can be onycholytic as well. So this is a medical emergency that will require dermatology consult and intensive care treatment to ensure that baby and mother are monitored closely. The last type of psoriasis is erythrodermic psoriasis, which is a dermatological emergency as it normally involves more than 90% of body surface area, and patients can be systematically unwell with fever, dehydration, hypothermia, heart failure, etc. Let's move on to the advances in the treatment of psoriasis over the years. In 1950s, methotrexate, which inhibits the dihydrofolate reductase, was introduced, and it proves to be an effective medication to treat psoriasis up to this day, but not without its own risks, such as transaminitis, chronic liver disease, and pancytopenia. In 1980s, cyclosporine, phototherapy such as psoralen with long-wave ultraviolet light, UVA, and retinoids were introduced. And in the year 2000s to 2020s are quite exciting as there are various biological therapies being introduced, such as TNF-alpha inhibitors, IL-12/23 inhibitors, IL-17 inhibitors, and recently TYK2 inhibitors as well. These are very effective treatment modalities to treat psoriasis and psoriatic arthritis. This slide shows the target of biologic therapies in the pathogenesis of psoriasis, where ustekinumab inhibits IL-12/23, infliximab, adalimumab, etanercept, and golimumab inhibits TNF-alpha. Risankizumab and tildrakizumab inhibits IL-23, which is more upstream. And secukinumab, ixekizumab, and brodalumab inhibits IL-17 pathway, which is more downstream in the inflammatory pathway. So can comorbidities be prevented by early intervention? Psoriatic arthritis is preceded by skin involvement in nearly 90% of patients and by an average of 7 years. Therefore, early identification of arthritis, enthesitis, or dactylitis by dermatologists is paramount. Controversial data that studied 15,000 US-based electronic medical records showed a lower risk of incident psoriatic arthritis among patients prescribed with IL-23/12 inhibitors and IL-23 inhibitors compared to patients prescribed with TNF-alpha. Before we move on to our case study, I would like to introduce PASI, which is a common clinical assessment tool for psoriasis. Psoriasis Area and Severity Index Score, or in short PASI, is an index used to express the severity of psoriasis. For each body section, namely the head, arms, trunk, and legs, assessment of these components are performed, where the percent of area of skin involved with psoriasis is documented, and the severity of 3 clinical signs, namely erythema, induration, and desquamation on a scale from 0 to 4 is documented. And a total PASI score will be generated, and the higher the score indicates the more severe disease. And what are the aim of treatments for psoriasis? It is recommended to use PASI 75 to measure primary response of psoriasis. PASI 75 is a binary outcome that indicates a 75% or greater improvement in PASI score from baseline. And as more new treatments are being introduced, the aim of treatment for psoriasis is also being pushed to achieve better outcomes, with patients expecting not just PASI 75, but even up to PASI 90 and PASI 100, which is clear skin. Let's look at our case study. This is a 40-year-old lady, married with no children, who had been suffering from psoriasis for many years, which did not respond to our conventional treatments. Her baseline PASI score at day 0 was 24.5, with a body surface area involvement of 60%. This had greatly affected her self-esteem. And before the treatment with biological therapy, she had psoriatic plaques affecting her hairline, her eyebrow, her cheek, chin, neck, trunk, back, and much thicker and redder plaques affecting her legs. On top of that, she also suffered from back pain, which is part of psoriatic spondylitis. Taking into account the psychological impact of both psoriasis and psoriatic arthritis are causing to her, she was hence started on IL-23 inhibitor, which was subcutaneous guselkumab, 100 mg stat at week 4, then every 8 weeks subsequently. So this picture shows the involvement of psoriasis over her trunk, abdomen, upper and lower back, and she also suffered from metabolic syndrome. This picture shows thicker and redder psoriatic plaques affecting her thighs and legs. So at our next assessment, which was 4 weeks later, and after 1 dose injection of subcutaneous guselkumab, her PASI score had improved to 9.3, although her body surface area involved was still 20%. Her psoriatic plaques were less red and thick, as shown in the clinical pictures here, and her PASI score had improved by 62% by week 4, which is a huge improvement. So as you can see, her psoriatic plaques are less red and thick over her back and arms. Similarly goes to psoriatic plaques over her thighs and legs. At week 12 assessment, she was happy with the progress, and her PASI score was now 5.1, although her body surface area involvement was still 20%. In this lady, her PASI score had improved by 79% from baseline pre-treatment PASI score. And as you can see, the plaques are much redder and much less thicker now. And her self-esteem had also improved. Her back pain has also disappeared. So in conclusion, psoriasis is a chronic relapsing disease that has substantial negative physical, psychiatric, and social consequences. Let's work together to raise awareness of psoriasis as a serious inflammatory and immune-mediated disease and a global health challenge on World Psoriasis Day. And healthcare professionals need to be aware and screen psoriasis patients for its various associated comorbidities to ensure early treatments. So before I end my presentation, let me introduce the theme of World Psoriasis Day 2023, which is access for all. We hope people with psoriatic disease will have affordable access to the right treatment at the right time. These are my references, and thank you for your attention.
Thank you, Winhui, for the very comprehensive overview and informative sharing on psoriasis. And I think it's great to raise awareness about World Psoriasis Day since it's coming up, and it's actually quite a common disease. We've got a question in the chat. All right, so someone's asking, are the patients need to be on medications lifelong for both genetic mutation type and non-genetic type? I think actually, I'm not sure what that means, but anyway, or it usually subsides after treatment for a certain duration. For the latter case, any relapse? If yes, what is the rate of relapse? So I think you might need to clarify, Winhui.
Yeah, so for patients with psoriasis, as I've shown in my presentation just now, is caused by multifactorial. So genetic is part of the reason, right? But it can also be triggered by a lot of factors such as infection, sepsis, and things like that, stress and things like that. So therefore, patients with psoriasis, when they were diagnosed, we tell them they will need medications, but it really depends on the progression of the disease to decide what medication they need to be on. So they can get better and later on, and therefore we can start to cut down the medication. But later on in life, let's say the psoriasis recurs, then we will need to restart them back on the medication. But obviously we start with medication with the lowest risk, like topical creams and things. And if it doesn't work, then only we go up to systemic agents. I hope that answer your questions.
Thank you, Winhui. Yeah, so generally, as she said, psoriasis is multifactorial and it generally does last. It is a lifelong thing, but like she said, the treatment, it depends on your condition at that point in time. They don't necessarily need to go to systemics all the time. So if you look at the CPG, actually it depends on the severity of disease and then we tailor accordingly. All right, are there any further questions from the audience? Let's see. So I think if there are no more further questions, I'll just, I think there's let me see. All right. So thank you again, Winhui. Thanks for joining us today. And so if there are no further questions, we'll move on to the second topic. We'll pass over to the ophthalmology team for their discussion. Thank you.
Thank you.